So picture this. A gastrectomy, the surgery to remove part of the stomach, can be an absolute lifesaver for someone with gastric cancer. It's often a cure. But what happens when that very cure, years or even decades down the road, actually sets the stage for a new kind of danger? A threat that could be growing in the exact place that was supposedly saved. And that's really the big question we're going to dig into. After a life has been saved, what on earth could possibly be this new danger? It's a pretty fascinating medical mystery, and solving it takes a ton of vigilance, skill, and a really deep understanding of what you're even looking for. Well, this new threat has a name: remnant gastric cancer, or RGC for short. Now, this isn't the old cancer coming back. Nope. This is a completely new tumor that pops up in whatever is left of the stomach. And here's the kicker. It can happen whether that first surgery was for cancer or for something totally benign, like a peptic ulcer. So let's dive into our first section, a cancer after cancer. It sounds like a paradox, right? And it is. The very operation that can cure you can, over a long period of time, create the perfect conditions for a brand new fight. First off, let's just be clear about how incredibly successful that initial surgery usually is. I mean, in Korea, the 5-year survival rate for gastric cancer was up to 77.5% by 2019. That is a massive achievement. And it just goes to show how effective surgical resection is. For most patients, they are, in fact, cured. But this is where the timeline gets super interesting. The risk of RGC seems to operate on two totally different clocks. If your first surgery was for cancer, this new cancer tends to show up relatively quickly, usually within about 5 years or so. But if the first surgery was for something benign, that danger can just lay dormant for an incredibly long time. We're talking almost 30 years later. So how does this even happen? Okay, let's move on and look at how the original surgery basically creates a new blueprint for the stomach. A blueprint that tells us exactly where this new cancer is most likely to hide. Right, so after surgeons take out part of the stomach, they've got to reconnect the plumbing, so to speak. This diagram shows the two most common ways they do that. On the left, you've got the Billroth I, where the stomach is reconnected to the duodenum, but on the right, you see the Billroth II, where they bypass the duodenum and connect the stomach a bit further down. And these aren't just minor details, they create completely different environments inside the body. And this right here is the critical clue. The type of reconstruction tells doctors where to focus their search. With a Billroth I, a new cancer usually shows up in the main body of the stomach. But with a Billroth II, it's most likely to be found right at the anastomosis site, that new surgical seam. And why is that? Well, it's thought that the Billroth II can lead to more bile reflux, which is constantly irritating that one specific spot. So you'd think, okay, we know where to look, this should be easy. Well, not so fast. Our next section explains why finding RGC is a lot like investigating a very, very challenging crime scene. Which leads us to this question. If we have a map and we know the likely hiding spots, why is RGC just notoriously hard to spot during an endoscopy? What's the deal? Well, the answer is that the crime scene itself is a mess. The leftover stomach is smaller, it's often shaped funny. The connection site is scarred up and deformed. All that bile reflux we mentioned changes the color and texture of the lining, which basically acts as camouflage for cancer. And to make things even worse, sometimes food gets stuck in there, hiding the evidence. And the tissue is so fragile it can bleed easily, making it really tricky to get a good look. But despite all those challenges, doctors have learned to spot the really subtle signs. So let's move on and take a look at the actual visual evidence they're hunting for. The clues aren't always a giant flashing red light. They can be a little raised bump, or a flat spot that's just a bit discolored, or even a tiny ulcer. It takes a really sharp, trained eye to tell the difference between these and just normal post-surgery changes. So come on, let's play detective and check out the evidence for ourselves. Okay, this slide shows the two main faces of RGC. On the left, you see a pretty distinct, raised, lumpy lesion. That's the kind you typically find in the main body of the stomach. But now look at the one on the right. The evidence is so much more subtle. See that flat, kind of sunken-in area? That's the type of lesion you see at the surgical connection point, and man, is it easy to miss if you're not looking carefully. So this really hammers home a super important point. The evidence is pretty clear. The way the cancer looks often depends on where it is. Those elevated, bumpy ones tend to grow in the main part of the stomach, while the flat or ulcerative ones pop up right at that surgical connection. And it gets even trickier. Check out these other examples. On the left, that's a classic ulcerative mass, right where the surgery happened. But on the right, we've got this round, reddish mass. What's so sneaky about this one is that it could easily be mistaken for something benign, like just some simple scar tissue from the surgery. And that is exactly why biopsies are absolutely critical. You just can't trust your eyes alone.
So, what's the verdict here? How do we protect these patients? Well, the solution isn't some new pill or another operation. It's a strategy built on being relentlessly, and I mean relentlessly vigilant over the long haul.
This timeline really tells the whole story. It shows you exactly why that long-term follow-up is so important. For patients who had cancer before, the highest risk is in that first 5 to 10-year window. But for the folks who had surgery for a benign issue, the real danger zone doesn't even start for 15 to 20 years. Vigilance isn't a short-term thing. It's a decades-long commitment.
And just look at how that risk explodes over time. For patients whose first surgery was for a benign disease, the risk of getting RGC more than doubles after 25 years. Wait 40 years, and that risk has jumped more than 7-fold. The threat doesn't fade away with time, it actually gets stronger.
So the bottom line is this. The whole strategy is active surveillance. The recommendations are crystal clear. For the post-cancer patients, you've got to be looking every single year, especially in that high-risk decade right after surgery. And for the post-benign surgery patients, the clock really starts ticking at that 15-year mark. That's when the regular checkups have to begin, because finding it early is the single biggest factor in getting a good outcome. You know, when you think about it, for these patients, the original surgery wasn't the end of their story. It was just the end of a chapter. And that leaves us with a final thought. In this long, silent wait for remnant gastric cancer, is our most powerful weapon simply the willingness to look again?